like, how do you feel about it in general?
And respect. And now we're going to take your questions. So we look forward to that.
Elizabeth and Joseph, did you hear that first question?
No.
Oh, okay. Kristen, if you will ask that again, I think we're all ready to go now.
Sure. I just wanted to know, like, your thoughts on Vivitrol. Like, do you feel that it should be, do you feel it's a good tool for the individuals to use? I know personally, my younger brother had used it and he had great results. And he's been in long-term recovery now for over 4 years. And it kind of just blows my mind that it doesn't seem to be offered as much as it should, just because I have heard positive things about it, but it doesn't seem to be offered as frequently as other things.
Yeah, it's a great, and can you hear me?
Mm-hmm.
Yes, it's a good question. For those who don't know, so Vivitrol is an injectable, long-acting form of medicine called naltrexone, and it is approved by the FDA for treatment of both alcohol use disorder and opioid use disorder. In terms of our unit where we work, so I will say the vast majority of our patients are individuals who are uninsured. It's about 90 to 95%. For alcohol use disorder, we typically would offer oral naltrexone, and then if they had an interest in transitioning to Vivitrol, there was a particular clinic locally that we would refer them to that had a pretty robust patient assistance program where they could enroll uninsured and clients that met their financial hardship criteria to get Vivitrol. For opioid use disorder, we went through a period of time on our unit where we were very aggressive with having folks stay on our unit a longer period of time who were interested in induction on the Vivitrol, and then actually to work with the PAP and get their first injection here on site, and then to follow up in our clinic downstairs. We have an on-site clinic, like a step-down clinic for following some folks to discharge. And we had a cohort of folks who got their first Vivitrol injection for opioid use disorder on our unit, and then would follow up in our associated clinic for monthly injections. We had another group who were inducted on the Suboxone, or buprenorphine naloxone, and then followed in our clinic. And I will say for our clinic, the data that we collected really showed that a substantial percent of our patients fell out of treatment after usually about 2 to 3 months with Vivitrol. And we were not seeing that effect with the folks that were getting buprenorphine and naloxone. And so because it actually involved them staying on our unit for a longer period of time, which affected our throughput, we do occasionally offer that for folks, but we have really backed off on that, just mainly because of what we have noticed with our specific patient population, that we've not seen the success. I will say Vivitrol is an evidence-based pharmacotherapy in real life for opioid and alcohol use disorder. And there are individuals that get quite a bit of benefit from it. In our experiences and with our patient clientele, we did not see the robust benefit for opioid use disorder.
And when patients do have Medicaid or have insurance, and we sometimes get them, I'm more likely to recommend it because the barriers are not so great to receive it.
It's really expensive.
Yeah, it's super, particularly Vivitrol. Naltrexone is fine, but they just have to remember to take it, and it becomes a much more complicated process. So, but we do offer it, and again, as Dr. Williams said, since they have to be off opioids for an extended period of time before it's inducted, it does create problems that usually patients often will want to leave or not want to stay that length of time, or agree to it and then halfway through say they back away from it. It takes a commitment to the Vivitrol to get that going. Whereas the Suboxone is more immediate. It cause a more immediate treatment.
He got it in Pennsylvania, and he was paying only $1 a month. for it.
Yeah, well, they've expanded Medicaid there. They have it here. So the options in Pennsylvania are significantly better
Yeah,
than they would be.
Definitely, definitely different, at least.
Yeah.
And I will say, I mean, Alkermes, the company, it does, excuse me, it does offer, you know, a fairly robust patient assistance program. It requires some, you know, someone in the staff, you know, has to be kind of appointed as the go-to person to, you know, stay on top of the paperwork and then having the medication like shipped over. And then for our unit, again, with so many of our folks being uninsured and needing to rely on that pathway, it was, it took some legwork by our staff. And then also the folks did have to stay here a little bit longer than otherwise they would have, just to actually get the first, you know, to be here to get the first injection before they walked out the door. And so then there was some pushback from that in terms of throughput, looking at, you know, our sources of referring patients to be admitted. You know, they always have concerns whenever there's like a slowdown of our discharge rate. But I mean, it is an effect, you know, there is clearly evidence in the medical literature to support its efficacy. And, you know, there are certain benefits that attach to Vivitrol over opioid agonist therapy in so far as a lot of programs that we work, like longer term rehab programs, you know, for whatever reason, they're maybe not comfortable or not equipped to manage clients who are on opioid agonist therapy, but they have more comfort level with folks who are on opioid antagonist therapy. And then certainly, you know, some patients, they are just much more comfortable being on a non-controlled substance for treatment of their use disorder.
Thank you. I've just always been curious as to why, like, maybe it wasn't, I don't know, not necessarily pushed as much as some of the other things, but I'll say encouraged. And not necessarily your company, but also where I work as well, and many of the other places that I know of. Thank you.
Thanks. I see Keith, you've got a question. Do you want to unmute and ask that one? Ooh, hold on, Keith. You're still on mute.
Now still.
There you go.
No, hey, all right. Hey guys, I work at Clinic B part-time, right down the street from you guys, and yes, with Heather. And you know, I'd say about 99% of the folks that we see and that wind up seeing you guys at some point are all crystal meth users. In the HIV community, that's exploded. We don't see a whole lot of opiate use, surprisingly. So I was just curious about you guys' thoughts on, you know, how that works with you guys, and if you're seeing, you know, an inordinate amount of meth as we are, and you know what you guys, because I know it's not a detoxing drug, it's more about crisis stabilization. So I'm just curious, you guys' thoughts about, you know, meth use and what the detox withdrawal / from meth, how that's being handled in general, not just with you guys, but globally, of what you hear in communities.
Yeah, it's a great point. And I would say definitely we have noticed a substantial increase in the percent of our admitted patients who have methamphetamine use disorder as a co-occurring diagnosis. As you mentioned, because we are an inpatient-based withdrawal management unit, it is very, very rare that someone is admitted to our unit solely for management of stimulant withdrawal. So typically we're seeing it in the context of folks that are admitted primarily either for like an alcohol or an opioid use disorder and have it as a co-occurring use disorder. And it presents, you know, certainly a lot of challenges because you know, there's not really effective pharmacotherapy for it. And B, you know, I mean, the literature and the studies looking at how methamphetamine use, especially heavy methamphetamine use, affects, you know, things like prefrontal cortical function, things that we would, you know, want our patients or our clients to have, you know, in their armamentarium for, you know, being able to have better impulse control or higher executive functioning, things that part of the brain really is responsible for, you know, is targeted by methamphetamine. And it takes months, from even when the person stops using to when that function would return to what we would consider essentially baseline. And so it is a real, I'd say it's a real barrier that we notice for folks to really kind of stay engaged in treatment. And we see that in our step down clinic, where some of those folks who have that as a co-occurring use disorder, that their outcomes are worse than in terms of staying in treatment than folks who do not have that co-occurring methamphetamine use disorder. And then of course, the data is pretty clear in terms of the increased prevalence of folks who are dying of overdoses, primarily from opioids, who are also using psychostimulants, primarily methamphetamine, also cocaine and other stimulants. But I mean, from a safety standpoint, it's really been a problem. The last thing that I will say is a lot of individuals at where we work at UNC Health on this campus who are admitted, and it's really primarily for treatment of their methamphetamine use disorder. They are usually admitted to our sister unit, which is a facility-based crisis unit. And often it is to address the significant affective symptoms and often psychotic symptoms that occur along with methamphetamine use, where it's not a quote unquote detox need they have, but it's a stabilization need. And so for that reason, it's a little skewed where our particular patient population, it's always in the context of them having a co-occurring like opioid or alcohol use disorder, which is actually like their portal of being admitted to our unit. But yeah, we're noticing, I mean, and like you said, certainly in certain populations, it is grown more, and it's a real problem with, I think a lot of work needs to be done in the profession of addiction treatment and addiction medicine to develop better treatments, better pharmacotherapy, and also better, non-medication therapeutic solutions for it.
Awesome. Thank you guys. Yeah. Cause like I said, we're flooded. That's all we see. So, and it's really tough. That's what I've heard from folks is that, we go and, not just you guys, just in general, that people are told, well, we don't really do meth stuff. And, so it's difficult, but it's a huge problem, at least what we see in the HIV community.
Yeah. Oh, definitely. And it's increased exponentially in the last 2 years. There's no, a lot of our opioid users are now methamphetamine and opioid users, where before they were just strictly opioids. So it's really flooded the community lately.
And the last thing that I would say on that topic is, a lot of our clients, when they discharge from our facility, many of them will discharge into substance use recovery houses. And they are administered drug testing there. And so, we can set them up with some pretty robust treatment for, say, their opioid use disorder. But, often what happens is they will be asked to leave that recovery house when they are testing positive for a stimulant. And, it really then destabilizes them altogether, and then often they will fall out of treatment with their opioid use, and it's just it's certainly a dangerous cycle.
Yes, definitely.
Brutal. Awesome. Thanks a lot, you guys.
Yeah.
Well, thank you.
All right, I don't see any other hands up, but does anybody else want to unmute and ask a question?
I'll ask another question.
Yeah, come on.
Since nobody else will say anything, I'll talk. But I'm just curious. I was at a conference a few years ago. It was, I think, the Meth and Stimulants conference down in Atlanta, and one of the speakers talked about some really early research that was being done with using stimulants, using very low dose stimulants for stimulant withdrawal, for meth and stimulant treatment. And I was just curious what you guys' opinions were on that, and if you've seen any other research. I haven't seen anything to follow up, but just curious, you guys' thoughts on that? Or
yeah, so there have been a lot of different avenues pursued for different types of medication treatments for a stimulant use disorder, especially like an amphetamine type substance. And one of the thoughts behind that is if you have them on a medication that has stimulant properties, that's dopaminergic, and you're having them on a medicine that they can take in a way that's not like injecting, or that would put them at a risk of an infectious disease, or that it's not causing them like the euphoria or the high that would be reinforcing from the addiction development potential, but is stimulating that dopamine reward pathway and preventing that dopamine depletion syndrome that we see and folks complaining about when they're abstaining from, say, methamphetamine use. That it makes sense theoretically where there would be some utility to that. And sure enough, there have been some studies shown that being prescribed either something that would be like a methylphenidate or an amphetamine type substance has some benefit. There are some studies showing some, I think I would say, modest benefit. None of them are FDA approved for that. And unfortunately, there are no FDA approved medications for stimulant use disorder, including methamphetamine. But there is some evidence about that. One of the things that can be problematic from our standpoint in terms of our clientele and who we're often referring our patients to is the comfort level or lack thereof that a lot of the agencies that we refer these folks to will have in terms of taking on the responsibility of appropriately monitoring someone who is on a controlled substance. And so there can be a barrier there. I will say from a medication standpoint, so there is mirtazapine, which is Remeron is the trade name of that. It's something that's FDA approved for depression. There are a couple of different randomized clinical control trials showing that medication at a dose of 30 milligrams a day, it's usually given at night, is superior to placebo for treatment of methamphetamine use disorder. And so it is rare that we offer pharmacotherapy here solely for meth use disorder. I will say if that person has a co-occurring depressive disorder or anxiety disorder, that is often the antidepressant that we will offer, just trying to follow like evidence-based medicine practices that there's a bit more robust evidence to support that. And then within the last year or so, there was a paper that came out looking at the combination of Vivitrol and bupropion, which is Wellbutrin. And again, that's a dopaminergic medication, that combination has some benefit for treatment of methamphetamine use disorder. But I mean, a lot of different medications have been looked at. Some have some modest benefit. I'd say, the issue of psychostimulants is one that I think is probably maybe underappreciated, just because often folks do not want to get into they don't want to take over maybe the responsibility of prescribing a controlled substance, and then the due diligence and monitoring that comes along with that.
Yeah. Oh, great. Thank you. I appreciate it.
And then also the last thing that I'll add about that, it is not uncommon for individuals who have methamphetamine use disorder to actually have a co-occurring attention deficit hyperactivity disorder. And so the other thing that this begs is, if they have a moderate or severe methamphetamine use disorder, they would need to be assessed for whether or not they actually have an ADHD that would certainly benefit from pharmacotherapy. And I think the research there is quite clear where treatment of that then would confer a benefit not only on their ADHD symptoms, but also to help address their stimulant use. So like if they have that co-occurring disorder, I mean, they are the mainstay pharmacotherapies for ADHD, that class of medicine.
The folks will certainly tell you they have ADHD. I've never met a crystal meth addict that didn't have ADHD, according to them. but it's true. I mean, and it's, if stimulants work for ADHD, it stands to reason that people with ADHD and predilection for addiction are going to wind up there. So, well, cool. Thank you guys. Appreciate it.
And they certainly do say they're self-medicating often. Like that's why they enjoy the meth. So that would make sense.
And then there's the whole chemsex thing, but that's a whole nother session.
Yeah.
Thanks very much, you guys.
Sure.
We have about 8 minutes left with our wonderful speaker. So any other questions? I always say I'm a teacher, or I used to be, so awkward silence does not bother me. I am happy to sit here. If you don't want to ask it out loud, you can type it in the Whova chat and we will read it out loud for you if that would make you more comfortable.
And also the attendees today, do they have access to our email addresses?
I'm not sure of the answer to that, actually.
I think it's on the
I thought
on
we
the
had
handout,
put it in,
yeah.
And so
Okay.
I say that because, you know, certainly if anybody has any questions or anything that they want to discuss further that they think about later, you know, please do not hesitate to reach out to, and I would suggest maybe including both of us on the email there. And then we would be happy to respond.
And if for some reason anyone can't find it, you can always contact us at APNC and we'll get you back connected and all that. So that's definitely not a problem. All right, well, someone did ask, and I'm not sure if that person is in here. The question just says in the question and answer, can you address secondhand smoke? That's all the question says. So I don't know. I know you talked a little bit about campuses being tobacco free. I don't know if I don't remember off the top of my head anything about secondhand smoke, but.
Yeah, so you know, for when you're talking about an inpatient or residential withdrawal management, you know, unit or level of care, you know, really increasingly there are fewer and fewer programs that allow smoking, you know, on the premises. Certainly our facility is a smoke-free facility. They can, you know, receive a nicotine replacement therapy, but there's just not the provision to go out for smoking breaks. So, you know, it's really from affecting the treatment here, like it's not something that we have to be concerned with, just because none of the clients, both when they're on our unit or when they're outside for fresh air breaks or outside, that they're going to be exposed to that.
And I believe the facilities we send them to, and that's where most of the tobacco use takes place. I don't think they're allowed to smoke in the facility for that reason, but they can smoke outside, like on the porches and things like that. But it is the number one reason people will, I mean, when I'm sending a patient to a facility, if they're allowed to smoke is a primary driving force between them choosing the facility or not. So they're going, if smoking is allowed, they're going to go. So to me, as a harm reduction, I'm okay with their smoking as long as other people know who are going, who are non-smokers, that there may be tobacco smoke there and that they may be exposed to it, but usually within the house proper, they wouldn't be exposed to it. So you'd have to step outside to be exposed to it and stand with somebody who is actually smoking.
And there is that, is it this upcoming July, where all campuses are going smoke free?
Yeah.
Yeah, so it's about to be even more of a mood issue.
Yeah, but
as we
I
lead
will
up to that.
Yeah, and just to build upon what my colleague was saying, I know we addressed this briefly during the talk, but untreated or undertreated nicotine withdrawal is from our standpoint, is an underappreciated reason or motivation for wanting to leave treatment early here. It is, you know, we have an algorithm that is followed in terms of determining, based upon how much someone smokes, their nicotine replacement, what would be ordered for them. And what I have observed is that it typically is, it lowballs
Yes.
what their perceived withdrawal state is. And so it is not uncommon for us to have to adjust their nicotine replacement regimen during the course of their admission. And it is a reason for why people leave treatment early. And I realize that people could say, well, maybe they're offering that as the excuse or the reason, maybe they're ambivalent about being there. I will say, when we're able to adjust their nicotine replacement, you know, more robustly, that typically does the trick. So I'd say, you know, if people are working in withdrawal management units and they're noticing, you know, a high percent of folks that are leaving early for reasons that are not entirely clear, one thing that maybe you would want to take a look at is what the nicotine replacement protocol or strategy is there. And also if staff are proactively asking about how they're doing with their nicotine cravings. Also, the nurses in our unit are very good at providing patients with education about how to use like the gum, because it's not just a gum that you chew like chewing gum. There is a technique to how that is done in order for them to actually, absorb the nicotine. And so if they're not using the nicotine replacement product appropriately because they don't know, that can be a problem as well. But it really is, it's not an insignificant issue.
Right. It needs to be addressed, particularly if any of your campuses are going to become nicotine free. Be prepared to really offer robust replacement therapy, because I can guarantee it is a huge barrier for our patients when they don't have enough nicotine, and they really, sometimes they need to be like overeducated on it. So I'll often start groups about NRT, and are they chewing their gum properly, and are they still craving, and so forth. I just check in with my groups just to make sure, because I think they often don't report it or underreport it or don't know. And so we really have to, I'm pretty aggressive about asking the patients about it, because it is definitely, and even when I say, I know some of you want the number one reason for discharge is to have a cigarette, they all nod. It's just, they agree, they know it's waiting for them downstairs. They talk about it endlessly. So when you get them talking about it, it's really clear that that's going to be a motivation for them to stay or not to stay.
So we only have 1 minute left, but this sparked 2 other questions. One of them said, can you clarify all campuses going smoke free? I know that there's, is it, oh gosh, I can't remember what it's called, but there's a coalition who has a ton of information on that and has, sample guidelines for how to implement that at your campus, that I can get the name of if y'all don't know either. And I can send it out to y'all. The other question was, what is the data supporting asking someone to stop smoking while asking for help for other substances, success versus relapse?
That's great. Yeah.
Oh yeah. So I mean, I don't have the data. I know
there are studies that actually say that it's people do better when they quit their tobacco use at the same time as their drug of addiction, whatever brought them in, their drug of addiction, rather than just doing it. Quit one thing at a time was the old adage, and that was never based on actual studies. But when they started doing studies, they found that it was almost 30% better outcomes, right?
And I will say, if any of the attendees there want some more specific information, yes, if you want to email us, one of my colleagues is really a subject matter expert about the literature about tobacco cessation and what the data shows in terms of the success of when that's done while addressing other substance use disorders. We would be happy to send it. Unfortunately, I don't have the information.
I have that article, but I don't have it all in my head.
That is really what the standard now has become, is that they would be addressed together, and that the previous paradigm of addressing one addiction at a time, or this thought that, oh, they're going to be struggling enough with their opioid withdrawal or their alcohol withdrawal, don't add another burden, that is not based in evidence.
Yes.
It's really, that is a very important time to address both of them, like, yes, their primary, whatever they got them admitted to a withdrawal management unit, and then their co-occurring tobacco use.
And since we are a detox unit, I will often remind the patients that they've done the hard work. They've stopped the smoking, they're on the patches, they're on the gum or whatever, and that we will help them maintain that if they want it. Because most people who smoke would like to quit eventually, so that when they think about it, they know that this can be an opportunity, actually. So we definitely advocate for that.
Awesome.
It's also a good opportunity for motivational interviewing.
Yes.
About addressing what their thoughts are about ongoing tobacco use versus cutting down or stopping.
Exactly.
All right. Well, thank y'all so much. This will this Q&A is recorded. It will also be available alongside all the other sessions. So for another 30 days after this. So if there's anything you heard that you want to hear again, you'll definitely have access to it. I want to thank Elizabeth and Joseph just one more time for joining us for this Q&A and for putting together everything you did for the session. And you guys have, I guess, 15 minutes before the next session. So, go get a snack or whatever, and we'll see you in 15 minutes. But thanks, y'all.
Bye.
Thank you.
Bye.
Bye.